Hello, Dr. Bruno.
Hello, how are you?
I'm good. How are you?
I'm doing well.
Oh, excellent.
It's nice to see you. Can you hear me well?
I can hear you well.
Great.
Awesome. And I can see you well.
There.
Perfect. Oh, got so many plants. That's awesome.
Yeah, I don't know for how long though, because it's the time of the year when they start to slowly die.
Where they kind of decide they're like, I'm going to be dramatic and just,
And then you come one day and every plant is gone.
oh no. Oh,
In the meantime, we enjoy them.
that's fair.
How much time do I have?
Um, it's slated for an hour.
Okay, total.
And I'm sure it's fine if we run a couple minutes over too. There's nothing like right after it.
And what about questions? Is it is they can say open mic and talk?
They could, or we typically have them put them in the chat. That way I can kind of group like questions, make it a little bit easier. And that, so that kind of, we can ask more questions, more different questions.
Okay, sounds good.
So yeah, I'll probably have them put them in the chat. And that way they can kind of type. So when I let people in, I'll put something in the chat to let them know like questions here, because typically it pops up for them then. And I'll let them know when I kind of go through our little scripty piece.
Perfect.
Awesome. I'm very excited for this webinar. I was like, please let me moderate. I was like, I want to learn all this information.
I hope people join. Like,
It seemed like we had quite a bit of interest, and there was a few women who were very excited to see like some women's health specific stuff around Parkinson's.
that's great. And do you see my slides or do you see the presenter mode now?
I see the presenter mode at the moment.
It's better.
Oh, there we go. Perfect.
Perfect. Good. Perfect. So I will leave it like that. So we know it. Or do you need to show a slide?
No, I don't have a slide or anything to show. I've got a couple of like little housekeeping pieces to kind of get things started. And that is about it. Yeah, they have their little like scripty piece, which is not very long at all. Mostly about where to put questions.
We'll have the chat open here so I can see also what is coming. And maybe if I'm in a part, you can answer.
Type out my stuff for the questions because I'm always trying to type it really quickly while I talk, and I'm like, it never goes well. How was your summer?
It was fast.
Yeah, agree.
Very short. Yeah, I didn't do as much as I expected in terms of relaxing and leisure.
Of the relaxing stuff, like more work than relaxing.
To be honest, is this unfair thing that you take a vacation and then when you come back, work has multiplied? It makes no sense because you are supposed to relax.
Right? You come back like, well, now I'm not quite as relaxed.
It's very sad. The million emails and you keep saying, I will do that tomorrow.
Yeah, like tomorrow, a tomorrow problem. Brandy does it all the time. She's like, that's a tomorrow problem. And I'm like, I know, but tomorrow comes so quickly.
Tomorrow passed so quickly. And the kids, my son started first grade, so there was a lot of preparation. The other one started preschool, so busy.
Oh, how sweet. Aw, hopefully they're enjoying their first couple months at preschool and grade 1.
I know.
Oh.
It's unique times. You also want to be present, you know.
Aww. I'm going to start letting people in. It was 5 for a second. All right. Give it another 2 minutes before we get started. We'll get started right at 1:30, and I'll watch for people to trickle in as well as we go. Okay. I think when we get started, I'll spotlight you, Dr. Bruno, and that way then you're kind of your slides, but then you're also show up there as well. I can't make it do it automatically for some reason. Well, we've just hit 1:30. We'll welcome everybody to our webinar today. So we've got Dr. Veronica Bruno here to do women's health in Parkinson's disease, so closing the gender gap. I'm very excited to see a bunch of people here today. A couple kind of quick things. So my name's Brianne. I'm one of our client service coordinators here with Parkinson's Association of Alberta, and I'll be moderating the webinar for Dr. Bruno today. So if you have any questions during the webinar, you can submit them in the chat below. I'll send a chat out too, so it hopefully pops up for you. But it's at the bottom of your screen. There's a little chat blurb icon there. You click it, the chat will pop up for you, typically on the right-hand side, or it'll pop up in front, kind of like in the middle of your screen. And that way then you can send questions out to either the whole group or just to Dr. Bruno and I. A quick disclaimer here. So this webinar is going to be recorded. So all information provided in the videos by Parkinson's Association and our featured speaker is furnished strictly for educational and entertainment purposes only. This service is not intended to be diagnostic, prescriptive, or replace the relationship, advice, and or care of your physicians. So general questions about symptoms, treatments, available medication, stuff like that related to this webinar will be fielded at the end here. And so gonna welcome Dr. Bruno here. So Dr. Veronica Bruno is a neurologist and movement disorder specialist and currently an assistant professor in the Department of Clinical Neurosciences at the University of Calgary. Dr. Bruno completed her medical and neurological training at the University of Buenos Aires, followed by a fellowship at the University of Toronto, and earned her Master's of Public Health from Harvard University. She's recognized as a leader in the field, both nationally and internationally, holding key leadership roles in organizations such as the International Parkinson's and Movement Disorder Society. Dr. Bruno is dedicated to advancing patient care with a focus on improving the quality of life for individuals with advanced Parkinson's and their care partners. Her innovative projects include tailored interventions to support this population and pioneering treatment options for pain and related Parkinson's symptoms. I am very happy to welcome you, Dr. Bruno, and I will turn it all over to you here to get started.
Thank you, Bree, and thanks everyone for joining. And hopefully we can use this opportunity as a, as an idea starter, like something to trigger more conversations and more connections between women living with Parkinson's. And you will hear me a lot saying that there's not a lot of research about this, and that's why we're here. So I will try to answer some questions. I will try to provide some information, but I think the main goal of the presentation is to bring awareness about the lack of data that we have and how we need to start building that together. So my presentation is called Women's Health in Parkinson's Disease, Closing the Gender Gap. And I will start with a disclosure, because while preparing the presentation, I thought, some people looking at the slides or listening to me may have this thought. So it's important for me to say that I define myself and identify as a feminist. That means that I have a strong commitment to advocating for gender equality and social justice. And while I accept and approach all viewpoints with openness, maybe my perspective will show in some of these slides, considering the topic of the presentation, particularly the ones regarding with empowerment of women and the marginalized communities. So most of women will likely be okay with that, but if there is anyone that doesn't feel comfortable with that position, I think you should know, so you decide what to do about staying or not. I also thought it would be appropriate to introduce some definitions, because you will see that in some of the slides I refer to women, and in some of the slides I refer to female. So as a very broad and not detailed enough approach, what we are going to do is, when we have information about biological sex differences, we will speak about sex and we will refer as female. So this will be when we talk about biological, physiological characteristics. For instance, that information that involves chromosomes, hormones, or other aspects that are related with the biological sex. While when we speak about women or when we speak about gender, we're using a completely different definition, related but not the same, that includes the roles, behaviors, identities, and the societal expectations associated with being a woman. Unfortunately, in the literature to date, those two terms were mixed up a lot. So we need to evolve and start to be more clear and open. If you notice that I misuse any of these terms, please let me know so we can continue to improve. Just to give you a bit of a background, I'm pretty sure you don't need this, but Parkinson's disease is a complex condition. It's neurodegenerative, it's slowly progressive, and classically what people know about it is about the tremors, the stiffness, and the slowness, what we call the motor aspects of the disease. But we know that the disease involves much more than that, and there is this big category of what we call non-motor symptoms that includes things like depression, anxiety, pain, constipation, urinary issues, sexual dysfunction, and other problems that are not classically thought to be related with Parkinson's, but have a clear implication in how the quality of life of people living with Parkinson's is affected. And as any condition that affects the human body and also the animal body in general, there are likely sex differences. So there are some studies that were done in animal models of Parkinson's or in a very epidemiological way in large populations of people living with the disease that show that females and males have some differences. So what do we know so far, or what information we have? And I will provide more information about how we know about this in a bit. So we know that women seem to have very unique Parkinson's disease experiences, like the way things are reported in general, or women report in comparison with men, is that there seems to be more tendency to have motor fluctuations. With that, I mean the ups and downs when taking medication, like feeling on and off, terms that you may discuss a lot with your neurologist. There seems to be some influence of how hormonal states like premenstrual and perimenopausal stages affect some of the symptoms, but we don't know exactly how or in which fashion or to which extent. And we seem to observe that the menopause may have an impact on the disease, but we don't know how or in which symptoms or again, in which directions. The reason why we don't know all that is because all the information that I'm providing comes from studies that were performed in large populations, including patients of like both sexes and multiple genders, without trying to clarify in detail what these changes were all about. We also have some idea, mostly obtained from clinical experience, about maybe women being more prone to anxiety, depression, and sleep disturbances, having more burden or more impact of the same burden of cognitive and autonomic symptoms, again, with an unclear information about why, and that pain seems to, in some case series, be reported more in females than in males. There are other aspects of the impact of Parkinson's in women's health that we have some information about. It seems that the non-motor aspects of the disease, again, all those related with the mood, with the bowels, with the bladder, affect quality of life much more heavily in women than males. We know that hormones seem to play a role, but again, not exactly how. And we know nothing about, for women that have young onset Parkinson's or are diagnosed before menopause, how pregnancy would affect the medications would affect pregnancy, or how pregnancy itself would affect the symptoms. We also know very little, but there's some studies about sexual dysfunction in women with Parkinson's disease. So this is something that has multiple explanations. If you go search Parkinson's disease and sexual dysfunction, you will hear a lot about erectile dysfunction. That is something that is important for men for sure, but may not affect female patients at all. It has also underreported because culturally, women are very, this has been shown in multiple studies, women are less likely to report sexual dysfunction to the neurologist. We recently conducted a review of 40 studies speaking about sexual dysfunction in Parkinson's. Only 2 of 40 mention women's sexuality as part of them. And again, as I mentioned, there is a lot of stigma and taboos surrounding women's sexuality, especially in previous generations. So that contributes to us having very little information about it. There's also some information about how women seem to be treated differently in terms of some of the therapeutic approaches that we use in Parkinson's. Even if overall it seems that the levodopa and the rest of the Parkinson's medications itself for motor symptoms are used similarly, women with Parkinson's disease have a higher prevalence of prescriptions of antidepressants and also benzodiazepines like clonazepam and lorazepam, that are medications that are commonly used for anxiety. Again, we don't have a biological difference to explain why this will be the case. So this is something that needs to be explored. Medication side effects also seem to affect female patients more than males, including females being more prone to dyskinesia, that are the abnormal movements that may appear when the levodopa is working very well. And also, as I mentioned, the ups and downs or motor fluctuations, as well as side effects like intolerance to some of these medications from a gastrointestinal perspective, or even drowsiness or other complications of treatment. And what is a bit more concerning, and you may or not identify with this according to what was your experience with diagnosis, is that this expands from the characteristics of the disease to the healthcare system. And women objectively have more issues than men with diagnosis. So the diagnosis in women is much delay. They found more obstacles having the healthcare providers believing and trusting that their symptoms are what they are describing. There are some studies that report that at least 5 years difference is the difference between the diagnosis time for a man and a woman, being the woman's one much delay. This also correlates with the fact that women are less likely globally to receive care from neurologists and medical specialists than men. And primary physicians tend to delay the referral to a specialized center of care in the case of women when compared to men. And also, there are multiple studies showing that the social support and the resources that women with Parkinson's receive are significantly less than the ones that men living with Parkinson's receive. Just to give you some specifics, some of our colleagues in the University here of Calgary and Alberta are working together because when reviewing the data, the historical data of which patients have been offered deep brain stimulation as a therapeutic approach, the large majority are men and are white men. So there is a clear bias and a tendency to provide more advanced therapies or more invasive therapies or information about those to men than to women. And also there are some biases in terms of like the minorities that come to the clinic. All this information, again, is obtained from case series or reports or experiences or studies that were based on a generic form that was sent to a lot of patients, and they had to mark or click in some symptoms. But the truth is, if you go look at what you read when you Google about Parkinson's and you search for studies, if you go in detail and you go to the clinical trials that were performed and the studies that involve big numbers, you will see that in the demographics table, when they show the difference between men and women, most patients or most participants are male. You will also see that around 90% or more are white men. So the historical information that we have about how Parkinson's disease shows, behaves, responds to treatment is based on that population. And in many conditions, that may be it. Let's say, I don't know, I want to give you an example, but in some dermatological conditions, it may be the same for white men than for anybody else. But we know for conditions that are in the central nervous system, that's not right. So there's this historical, what we call a historical bias to underrepresent women in studies. So we have all this lack of information or this giant gap about how particularly some aspects of women's health may be affected, and also a strong need for research. But again, this is something that you may relate or not to. It has been the experience of many of my patients that whenever they interact with other people living with Parkinson's that are probably male, due to cultural differences, males seem to be very much focused on finding treatments to cure the disease, very aggressive about that, and less interested in investing or spending time trying to find ways to improve their symptoms overall or improve their quality of life. That is unfortunately something that translates to the funding of research projects. So it's very hard to find ways to support financially projects that aim to look into this gap. So what is not known yet? So I gave you a little bit of a clue about that. But while I'm talking, I would like you to think about things that you may or not have thought about. So is this because of, so I will tell you some examples, but so many women, so most women are diagnosed after 65. That's the classic population that is described in the book. So you look for Parkinson's pictures and you see all these people that are elderly. However, we have a huge population of young onset Parkinson's disease, and many of these women may have reproductive cycles and may be interested in having a pregnancy and will go through the menopause while being diagnosed with Parkinson's. This is obvious because it happens to every single person, every single female patient or person in the world. And it's crazy that we have no idea about how, particularly the hormones, influence the symptoms. We have no idea how Parkinson's influences menopause or pregnancy. We also don't know how pregnancy, menopause, or cycles influence Parkinson's. Are any medications that could be making the menopause symptoms worse? Are any things that I could be doing better? So that's one of the biggest gaps. This has catastrophic consequences because for young women diagnosed with Parkinson's, this may trigger the decision of deciding not to have kids because of the potential risks without really having that information. So those are some aspects that require attention. Treatments are also very important. So I always say this, I tell this story. I have a friend who has Parkinson's, she's my age, and she called me like a few years ago and said, can I take contraceptives? Is that gonna make me worse? And I said, well, I have no clue, and I will search for it. And there was no one single study discussing the possibility of contraceptives having any interference with the symptoms of Parkinson's. And as you can imagine, the same happens with hormone replacement therapy and with treatments like hysterectomy. So we know, for instance, that estrogens have an impact on dementia, on Alzheimer's disease. That's much more explored, but in Parkinson's, we lack that information. Pain is a big thing. And, you know, how many times in general people, but women go to the doctor and said, I have all these pains. And they are so, okay, well, first, Parkinson's doesn't hurt, so it shouldn't be the Parkinson's. Second is probably all in your head. So unfortunately, that happens all the time. And you need to stretch more. And we know that that's not the case. First, Parkinson's hurts and hurts a lot in different ways. Like there are people that hurt because of too much stiffness or too much tremor or because the joints get in different positions. But there are also pains that we cannot explain. And there are pains inside of the mouth in Parkinson's that some people have, and pains that are related with nerve pain. So we have a lot of information now about how there is pain in Parkinson's, but how that affects particularly women, we don't know. We also may suspect that treatments may be different because, again, our body is biologically different. But again, that is not something that has been explored before. Sexuality, as I mentioned, is completely unexplored due to the stigma and the reporting. And the fact that because there's nothing that you pharmacologically can treat, that you don't take a magic pill to have an orgasm or to, change your sexual desire, while men can do that. So because there's not a pharmacological interest, it's something that nobody has explored in detail. And an aspect that, of course, has a huge relevance is mental health. Because if you read the reports based on no evidence, it will say that women with Parkinson's have more depression and anxiety. However, we have no idea of why. Is this a biological thing? Is because of their experiences, the difficulties accessing to health care? Is because of the family roles? Is because of the lack of support at home? So we don't know why that anxiety and depression is just reported, but the root cause of that was never explored in detail. Same thing with sleep. So women seem to sleep less or worse. It's because they feel cold or hot. It's because, they are overthinking because they have to still manage the full house and the partners and everything. Or it's because there is a real sleep problem that we need to explore. And then there's the social aspects that are part of the disease too. And it would be very nice if we were like little robots and we could separate the physical symptoms from the rest, but we're humans and we cannot do that, or at least most of us cannot do that. So how does Parkinson's impact your partner relationships? Not just in intimacy, but also in communication and in roles inside a house, caregiving. So naturally, people tend to think that women are the ones that give care. You know, it's this maternal instinct that we are supposed to have. But so what happens when we are the ones that need that type of help? When the person or the people that are around us need to become care partners. And this is something that for sure can have an impact on mental health and physical health too. And how does the diagnosis affect social interactions in general? People that, you know, like running or dancing or singing, and now that is a bit affected. So how does that impact quality of life? It's something that we don't know. And I think that a very important aspect for everybody, I'm not saying that this is not an important aspect for men, is about self-image. And you know, it's again, it's cultural, it's not everywhere about the same. But for sure, like we really need to find our identity in what we see. And at least in the experience in the clinic, sometimes like women more than men experience that the Parkinson's symptoms impact the perception of their own body, their identity, who they used to be, who they cannot be anymore, and also the stigma of embarrassment or not wanting to be seen having tremors or having dyskinesia because what people will say. And most of the women that I know never met other women with Parkinson's. And I think that's why this is so important. So thank you to Parkinson's Association of Alberta, and you are here. You get the possibility of joining a support group or a webinar and meeting other women with Parkinson's. But most people know mostly men with Parkinson's. So it's difficult to relate to other experiences or to find that support when everything that you read and see is about people that are completely different than you. And again, we going back to what we don't know. We don't know why there is a diagnosis delay for women. This happens particularly with younger women. And this is a bit catastrophic because now that we know that, for instance, the brain stimulation works better the earlier to do it in life, having a 5-year delay in your diagnosis delays your possibility of having a prolonged improvement in quality of life. So this is something that requires urgent repair. So it's because we're biased, thinking that women have more anxiety and everything may be anxiety. It's because the symptoms show differently. It's because women don't have the time to go to the doctor. What is that makes this happen globally? Again, it happens not in Canada, everywhere. Also in Canada, but not only in Canada. The symptom reporting, is there any problem with how physicians are reading the symptoms that women are reporting, or is because they are different? And why there is a tendency to treat symptoms differently? Is because there is a biological explanation for that, or is an overdiagnosis of mental health issues in women? So as you can see, I am not happy with this. I guess that's pretty obvious. And I'm not happy with the fact that when my patients come to my clinic and ask me these questions, I don't have any answer. I think it's unfair, and I would like to help at least covering some of these areas with some more information. So what we are doing right now is conducting a study that aims to close that gap. So we were very fortunate to receive funding from Parkinson's Canada for a pilot project that aims to generate some of that information that is missing. So we want to do it very patient-oriented, patient-centered. Because another problem that happened with research in this area is that researchers come with, oh, I want to see if female patients have more pain than men. And they design a study in a way that makes sense scientifically, but not sense in terms of what people are experiencing. So we want to start on the opposite direction. We want to start with what women with Parkinson's are experiencing. And we want to go through the full country, trying to get the most of the experiences in order to be able to provide answers. And I will tell you more what type of answers we're trying to get. So we want to explore the symptoms that are more like body related, like motor and non-motor aspects, particularly looking into all of them, but in those that have been underreported, like the sexual aspects, pain, mental health, but also exploring the personal and social impacts of the disease. And we decided to plan this study in 2 phases. The first phase that is using focus groups, and I will tell you a bit more about what that means. And the second part, creating a nationwide survey that we will use to get as much information as possible from people across the country. So the team, I'm really fortunate to have the team for this grant. So I am the principal investigator. I have a wonderful co-investigator that is present here in this talk, that is DA Dirk. So DA has Parkinson's, young onset. She's extremely young, and she got some years to be diagnosed. She's very young. And she is also a professor specialized in sex and gender studies. So she provides a lot of insight from a person with lived experiences, plus also because of her professional expertise. We also have Olga, that is our assistant, who is also here and is fundamental in organizing these and collecting the data. And we also have 2 collaborators, one from Italy and one from Toronto, both very much involved in the care of women with Parkinson's disease, who provide input too. We are extremely lucky because we also have Parkinson's Association of Alberta, and I'm very grateful to Randy and the rest of the team helping us disseminate the need of this type of research, and also part of the CAPRI, that is the Calgary Parkinson's Registry, supporting us in the recruitment for this study. So what does it mean to have a focus group? So basically it means contacting people that want to be involved in the study, have them come in person or through Zoom, like this type of encounter. We try to keep it small, between 4 or 5 to maximum 7 participants, so everybody has the opportunity to express themselves. And we are all women interviewers, so we reduce some barriers that may come up when we discuss sensitive topics, or sharing things about our personal life. Everything discussed in those focus groups is absolutely confidential and doesn't leave the room. And we go through open-ended questions about multiple aspects, like physical, emotional, life challenges, like stage challenges, healthcare experiences. And I think the most interesting part about this, independently of the research itself, is to hear that other women with Parkinson's have very similar experiences to the ones that you're going through. And I think that was a very rich aspect of the first experiences that we have. So we just launched it. We started the study last month, but I wanted to show you some of the things that are coming. So we only had 2 focus groups involving 9 women living with Parkinson's. The average age in these first 2 groups was 67.3 years, and we are open to any age. So people that participated so far between 60 and 80, and the mean disease duration is 8.5 years, but we have people very early in the diagnosis, like at 3.5 years, and people with very long history of Parkinson's of 16 years. The duration of the focus groups is 2 days of 2 hours each. And it's, again, some we can organize on Zoom, some we can organize in person, and we provide some snacks, and we, to be honest, have a lot of fun. So part of the first part is collecting this qualitative data. So listening to your experiences, putting them together and see which type of patterns we start to identify. Because again, we're all humans, we have different experiences, and what may affect me may not affect you. But we want to see if there is a pattern that seems to repeat. And some of just to give you some examples of the things that we have seen so far, are related with a lot of stress about the future. So participants express fears about future outcomes related with Parkinson's and what's going to happen and how it's going to affect my family and my life overall. Medication changes is another common topic. This thing of not knowing if these symptoms are menopause or not. Difficulties sometimes being heard as women, not only in the health system, but sometimes in their own house. Because again, women are the ones that, support everything and keep going in most cultures and many of the relationship models. So this feeling that my pain or my suffering is not heard was repeatedly mentioned. Sexual dysfunction, many people reported changes in the intimacy pattern that sometimes is not fully understood by the partners or not even discussed. Many patients, if not participants, if not everyone, mentioned their own strategies with physical activity and how exercise has changed a lot their tolerance to the symptoms of Parkinson's. And many also mentioned the challenge of finding a good guidance in terms of what nutrition aspects should they consider and how food can interfere with the medication, and how difficult it is sometimes to coordinate meals with the family and medication intake to try to make the best of each dose. It's very cool. I think this is the coolest part, how people report or share their own coping strategies, like how they do, a meditation, or how they keep track of a routine, making one thing at a time. And you can see how that is taken by other participants to see if that helps and it works. Patients have expressed challenges with body image and confidence. Not everyone, but it's something that came a few times. And there is a huge variability in the support from partners and family, but most people say that it's a fundamental aspect to get that support from family, partners, and faith when applicable for navigating the challenges of the disease. Some other topics that came out very frequently are the importance of connecting with others and how isolation and loneliness make everything worse. How there is a big worry about how to manage perceptions, like I don't want my friends to think this, or to have pity, or to feel pity, or to feel embarrassed. There's also a big concern about loss of independence, and there's also a common theme that seems to be related with, as the disease progresses, tending to reduce the social gatherings, and women that used to have these big parties and having everyone come in, starting to stop doing that because it's challenging and it requires a lot of energy, and they don't want to show that they require more help because they want to make everybody happy, and that becomes also painful for many of the participants. And the same thing with family roles, like most of, and again, this is very interesting to see as a daughter, because many of the moms don't want their kids to have a burden of having to take care of them. They want the kids to have their own lives and do their own stuff. And that brings some sadness, the fact that needing to ask more help sometimes, and they feel sometimes of guilt and inadequacy to fulfill the previous responsibilities came out a few times too. Again, very different and large broad of responses regarding the spouses support for those that have a spouse or a partner, with a little bit of a sense that sometimes, again, for male or men care partners, it's a bit harder to accept the diagnosis and the symptoms, and that introduces a barrier in the communication that, again, doesn't happen every single time, but when it happens, it's very difficult to deal with. For women that were diagnosed while working, there are some very, I think, interesting aspects, but most of them had to adjust their work to Parkinson's and because of Parkinson's, and most decided not to continue pursuing leadership positions and stepping down to a more like a lower category, if it's, I don't know how to call that perfectly, type of job, more like less exposed because of the Parkinson's. And a lot of people never mention Parkinson's to their employers or colleagues at work, and had kind of to hide symptoms when they appear because they were scared of the stigma that that would bring with that. Future planning is for sure a big deal for many people. The uncertainty and anxiety about what may happen in the future and how to try to plan proactively so there is less of a burden for people around, and care arrangements. And it's very interesting because I think this comes much more in women than men, the fact that they want to get everything ready, instead of again, adding that to the burden of their care partners. And other areas of concern include the lack of information about many of these topics. A lot of the discussion work around the menopause and these temperature changes, and am I cold? Is because it's a hot flash, or like am I hot? Is the menopause is not like how much we need that. And this relationship for those that have kids with the motherhood expectations and the Parkinson's. So, you know, I am supposed to take care of my grandkids. Am I supposed to be the one that is responsible when my kids have a problem? And now I feel that I cannot deal with those issues. So as you could see, the topics are broad. And the next step after this first step will be to collect information from as many women as possible, clarify which are the main aspects that our participants think are relevant. We have a huge questionnaire, and we are cutting it down as we are going because we're noticing that some aspects are much more important than others. Our participants also have the opportunity to go through all the questions and rank them from the most important to the least important. And our goal with this is, with a very good representation, end up having a final survey that is not too time consuming, that will be, again, distributed across the country. We really need more representation, and we want to make sure that everybody is involved if they are interested. So if you know other women, if you are not part of the study yet, as you could see, our range right now is between 60 and 80. We may be missing a lot of those women that were diagnosed in premenopausal stages. But we are really wanting to hear from everyone with different experiences, different generations, different type of problems. We want to capture every aspect that may be important for you. And again, after that, we listen to all these interviews with detail. We transcribe the quotes from the interviews. We use a special software that is used to identify this pattern or key themes. And then we start like getting the topics more separately or in detail of categories. And then, as I mentioned, we will send this survey. And with that, we aim to have at least 200 people responding, but hopefully that will be much more. We will use the C Open network. That's a Canadian Open Parkinson's network to distribute our survey. And the goal is like not to leave anyone outside and to be as inclusive as possible. So why do we do this? So it's not that we just want to, you know, fight the unfairness and say we need this information and stop there. We really think there is a lot of potential for hormonal potential treatments. And I'm not saying more hormones or less hormones, because we don't know. Personalized treatments, like, is levodopa really working differently, or is just administered differently, or is not explained properly? So how we can adjust treatments to make them more suitable for women. Healthcare access, for sure, that's a big priority. Everyone should have equal access to a good diagnosis as soon as possible. Training people, training family doctors, training neurologists, training nurses to increase the awareness about these particular aspects. Genetics research. So there are any genetic markers that may predispose like female patients to have some specific characteristics. Now that we're in an era where genetic testing is more available, is there anything that we could explore in that area? treatments efficacy, not just medications, but also is any physical therapy that would help women more than men, or at least should be used in a particular way in a specific population, and also alternative therapies. Because again, if we stay just with what we know, we have very limited options. So is there anything else that we could be doing for particular symptoms in women that we are not doing? So I want to have a lot of time for questions. I am very grateful for you having joined. I really, really would love to, if you see other women in support groups or in any networking events that have Parkinson's and want to participate, share the slides or share the contact information. This is the email of Olha, who will be collecting your interest and calling you to arrange your participation in the study. There's no need to participate fully if you don't feel like it. You may want to come to one session and see how it feels like. You could leave at any point if it's not for you. You could write a letter saying, I don't want to go there, but I think this is important and this has been my experience and I want you to keep that in mind. Unfortunately, I'm not the neurologist of all of you, so I cannot collect that in clinic. So feel free to, or sharing with your neurologist specific concerns. Something that came up a lot was I would never tell this to my neurologist if they don't ask. So feel free to ask these specific questions, but also feel free to email us and say, is this related with anything that you have mentioned so far? And again, I want to finish with a little very simple quote that is, about, alone we can do so little, but together we can do so much. We don't need to accept that this is it, that this is the lack of information that we have to live with. We have the resources and we have the capacity to regenerate the research to help women with Parkinson's. So with that, I will close. And I'm very bad with technology, but if you go to that little QR code with your phone, you're supposed to open the references, but they're also here listed. That is a more old-fashioned thing, but more effective. Whenever the slides are shared, you could download it, and there are those studies that I mentioned are there, so you could look at them or read them if you are interested. So I'm open to any questions. You can put them in a chat, or you can just bring your hand up if you prefer, wherever you want. And I don't know if DA or Olha wanted to add anything. I would love that if there's something that comes to your mind.
Well, I mean, I can just say from my perspective that I was diagnosed when I was 47, but it took a long time for me to get that diagnosis. I think I was showing symptoms at least from my early 40s. So I was one of those people who was searching for answers about what was going wrong and wasn't getting any of those answers. And then perimenopause and menopause hit me really hard. And I asked Dr. Bruno, have there been any studies done about the intersection of Parkinson's and perimenopause and menopause? And she said, I don't think so. There's not a lot of good stuff out there. So I found it very frustrating to sort of untangle what was going on. So here we are.
Thank you. Does anyone have a specific question? Anything you read? Anything based on your experience in the groups that you want to share?
Well, there was one question in the chat asking how long the focus groups are, and I think you touched on that, but just in case, do you mind just kind of re-answering that for them, just in case?
Yes, it's 4 hours total, and again, we have it divided in 2 days. And we are having a Zoom option in case you don't live in Calgary and you don't want to come all the way here. And there's also in-person option for those that are interested in getting more of the social part of it. And again, we learn a lot, we have fun, and I think it's the different. I tell the Parkinson's Association of Alberta a lot about having maybe a support group for women only. I think that the personalities are different, but men tend to it is scientifically shown that in meetings, men tend to speak much more than women. Men tend to take over many of the conversations and explain things multiple times, even things that women are trying to express. Again, this is no news, but it may be a good opportunity to have a space where everybody feels a bit more free to share some aspects or to show some feelings that may not be so easy to share. And again, not everybody experiences this differently. And I think that was the richness of these first two experiences, that you can see the faces on the other side, and you can see when some people say, oh, of course, that's exactly what happens to me. And some people said, I don't really ever had any experience like that. Some people had the wonderful diagnosis in time, support from family doctors, neurologists, very quickly. The partner is the most supportive partner in the world. The kids are there all the time. Some people do not have that. And I think it's our responsibility to take care of everyone with different experiences. Yes. So Wendy, I am going to answer that directly. So yeah, and DA we show her we tell her experience. Ongoing cramping in right foot is a symptom of Parkinson's 100%, and is many times the first one for years. And it usually is what we call foot dystonia, and usually has a very classic pattern. Not always the same, but it's curling of the toes. The big toe goes up and the foot tends to twist. But sometimes it's just the pain in the back of the leg, or just the curling of the toes, or just people noticing that in the shoes, the big toe is making a hole because it goes up all the time. That can be very painful. It can respond to levodopa, but usually the dose that we need to get rid of that is very high. And it can also respond, and we had a study done, and it's soon to come published, that using botulinum toxin for locally in the muscles that get the cramps is highly affected. Yeah, I think it's, I don't know how old are you, but it's unlikely that dehydration or a mineral hydroelectrolytic condition would lead to this type of cramp, especially if it's only one foot all the time in the same pattern. Classically, it happens in the middle of the night or early morning for some people, while for other people it happens while they're trying to walk. So I guess it's something to discuss with the family doctor. So I will, if you give me a thumbs up, DA, I will tell a little bit about your story. But DA is an athlete, she's a runner, and she started to have these issues while running. And that took her 1,000,000 years of, not a million, 5 years to, because someone said, okay, why is this happening, this foot all the time with this pattern? Could this be Parkinson's? Because they are not so clearly known aspects of the disease, even if they are extremely frequent.
Yeah, I was very lucky after this started when I was probably about 40, 41 when I was running, but it was getting progressively worse. And so finally, when I was about 47, I saw a physical therapist who diagnosed me with runner's dystonia. He's like, oh, I wrote a paper on that. I know what you have. It's runner's dystonia. You should go to the movement disorders clinic. But up until that point, I had seen a neurologist who just did a bunch of MRIs and said, I don't know. I had seen, physical therapists. I had seen, massage, acupuncture. I was looking for I went to the runner's injury clinic at the UFC. And like I said, finally, I just stumbled upon a person who happened to know about runner's dystonia and said, you've got it. And the Botox has been amazing. I was in that study with Dr. Bruno. It hasn't, 100% disappeared, but it's definitely really improved my pain, and cramping has been tremendously affected positively. And also I can run usually without dystonia. Before I could not run at all anymore. So the Botox has been very helpful.
And going to Melinda's question about if it is one of the first, it varies. So in younger patients, like DI's experience, it's usually one of the first symptoms. And again, it's not well known, so people don't diagnose it. In patients that are diagnosed later in life, tends to be a diagnosis that comes later when the medication needs some adjustment, or when the medication starts to show the ups and downs, especially at nighttime. You know, for many years, the nighttime seems to be a good time because you don't need much treatment. But then after 5, 6 years, the nights are getting difficult and it's difficult to turn in bed. And maybe the cramping appears. That is telling us that the dopamine levels have gone down and we need an adjustment. It can
you
happen.
hear me?
Yes.
Oh, okay. Sorry. I'm just listening. And sorry, this is Wendy. I had
Wendy.
you asked me some things I couldn't get into I was out of the meeting somehow. I could still hear you, but I couldn't reply. Sorry,
Yes,
I don't want to stop what you're saying, but I have more questions related to this, if you don't mind.
Yes, tell us. If we can
Okay.
help. And again, I'm not providing medical advice. I don't want
I
to
know.
but I think this is
understand.
a good like small group we can check.
I appreciate that. No, I appreciate knowing. And I'll be honest, I was hoping you were going to say otherwise about being a symptom, but it doesn't, like, I didn't notice it at night. Well, I guess it is at night, but it's not like big toe curling and the other toes curling under, and it's more, and it's more in like the arch of my foot. And I noticed it like when I was getting a massage, I started feeling like she couldn't touch my foot because it would want to cramp. It would respond like, so that's when I kind of noticed it. I'm like, oh, okay, it's like, yeah. And it's just, I feel like
yeah. So what you're describing is always the same pattern. So the same like arc, like getting like a bit like twisted like this, would you say? I will show you my feet. It's not gonna be fun. But
it's not twisted, and it's not in my calf. It's just
okay.
in my foot, in the arch of my foot, it feels like mostly, but
I think it's an important thing to discuss with the neurologist. It may go in one or the other direction.
okay.
I think it's also important not to do crazy stuff. What I mean with this is so common as a Parkinson's symptom that many people don't know and go for foot surgery that hurts like a lot. And, and then maybe it was easier to solve by maybe adjusting medications a little bit, or again, with the injections with botulinum toxin that are very simple, fully covered, so inexpensive and extremely effective. So before make any decision about, okay, is this or not, chat with a neurologist. Some neurologists do the injections, some neurologists don't. And it's like, you can always ask. Usually my colleagues that do not do the injections will send a referral to my clinic or Dr. Aquino's clinic or Dr. Gilmore's clinic or Dr. Carnick's. Now we have 4 neurologists that are fully trained in foot injections, plus 2 more that are training on it. So hopefully we will have a lot of people doing those.
Oh, that's wonderful to hear. And okay, my sister's Melinda on this chat, and I'm Wendy here. I'm like our dad has Parkinson's. He got diagnosed in 2019. He's 83 now. And what was I going to say?
Take it easy. I would take it easy.
I'm in menopause. Yeah, thank you.
First, it's great that you're here.
Thank you. And I appreciate this. Yes,
and we don't want you to have an experience of nobody answering those questions. I think it's very simple. You go to your family doctor and said, I want a referral, and we will see you and we will help you. And
thank you.
It may be nothing related, or it could be.
Okay, because I just noticed it in the last, I wish I would have recorded the date, but just recently, like I want to say within the last 6 months.
Don't worry, don't overthink about it. Okay,
I hope not. I just, because I'm 52 and I'm fully in the throes of menopause, and it's really debilitating, and I'm seeking help for that. But yeah, my hormones out of whack, the brain, my focus, and I have extreme ADHD right now, and like all the symptoms, every symptom I could have, I've got it.
Oh,
I'm like a poster child for menopause.
I hear you 100%. I recommend 2 books. One is by Dr. Jen Gunter, The Menopause Manifesto. The other one has a better title. It's called What Fresh Hell Is This? And it's all about
what? Sorry, what fresh hell did you say?
Fresh Hell Is This? It's by Heather Corina, Corinna. It's called Perimenopause, Menopause, Other Indignities, and You. But yeah, just if you look up What Fresh Hell Is This, you will find it.
Okay, thank you.
I wrote
And,
it in. I wrote them in the chat. But yeah, no, Wendy, it's important
Awesome.
for you
I-
not to think too much and just ask for help.
that's
And
hard for me not to do, but thank you. I will try, and I will definitely ask for help. Thank you. And I
I had
appreciate
a
your
question that came up,
relating.
Dr. Bruno.
sorry, yeah, Bree.
Awesome. Thank you. Sorry, I had a question that came directly to me. It was about the connection between so they're kind of explaining that they were diagnosed with restless leg syndrome and then the menopause stuff, and then later on a Parkinson's diagnosis. Is that restless leg syndrome a part of the Parkinson's? Is it separate still?
Yes, it can be separate, and it's separate in a lot of cases. It can be also related. So there are a lot of different conditions that share some commonality in terms of the substance in the brain being dopamine, the one that is affected by different. So for instance, again, I don't want to make Wendy more scared, but ADHD is also dopaminergic. I have it too, but a lot of people have it. Kids have it. They don't have Parkinson's, but it's dopaminergic. And no, don't overthink. There is also restless legs is dopaminergic deficit associated with others. So it's not uncommon for people with Parkinson's to have restless legs, but it's also very common for a lot of people to have restless legs and never developing Parkinson's, or people with ADHD not having Parkinson's is the rule, I would say. The exception is when a person has both diagnoses. So the fact that the problem when they are combined in Parkinson's is while some medications like levodopa relieve the symptoms of restlessness transiently, the higher doses can make them worse. So some people have to increase the medication for levodopa for the Parkinson's symptoms, and then that makes the restlessness worse. The good news is that there are other treatments that can help restlessness, like gabapentin, pregabalin, a low dose of some opiates, minimal doses. So there are alternatives for the management, as well as some dopamine agonists if there are no contraindications. I think what is important is also some medications can produce restless legs and can exacerbate restless legs in Parkinson's, for instance, some antidepressants. Antidepressants have a possibility of inducing those. And of course, other more known causes like anemia, low iron, renal kidney disease. So it's important to exclude all those before assuming it's related to Parkinson's and start treatment directly. I don't think Synthroid has been reported unless it's too high of a dose for what you need.
I have a question.
Linda, your hand up.
Yes.
Perfect.
I went to my neurologist and I told him I was having extreme sweating in the night. And he said that has nothing to do with Parkinson's. He didn't think that was connected at all. And he thought it was maybe menopause. Well, I'm way past menopause, but he just wanted to explain it that way, I think.
Yeah. You should have said, what is menopause? So they had to explain it to you, and then it would make no sense as an answer. No, that's extremely common. I would say of the 8 women that we have interviewed so far, 7 have that. And I think it happens to men too. So it's unlikely to be the menopause. So it's related with the regulation of temperature. Not everybody has it. But, it's the classic. So yes, true, there is a predisposition because, it's the classic thing that the husband wants the window open and the wife is covered like up here. But Parkinson's just exacerbates those changes from being very cold to being very hot and sweaty. And a lot of other things that are dysregulated, like having a lot of water running, like a runny nose sometimes, or very dry mouth. Those are parts of what we call the autonomic. There is a HOPE conference where I speak a little bit about this, and probably in the website about the autonomic dysfunction that involves the bladder, the constipation, the sweating, the saliva sometimes. So yeah, it's all part of the same. It's all part of Parkinson's. And sometimes there's nothing we can do. but sometimes it tells us that maybe medication needs to be adjusted a little bit.
Mhm.
Yeah.
Thank you. Any other questions? All right, awesome.
I actually am a physio myself, and my husband had Parkinson's where he had a tremor. I felt I had restless leg syndrome, and then it got to the point where the pain and some of the symptoms, they were thinking I had an allergy to the statin drugs. So they took me off the statin drugs, and then the year after I was diagnosed with Parkinson's, and my first symptom was the fascination where you, I almost felt like Michael J. Fox there. I was ready to fall on my face. And like that was in 23. And then just this last year, I now have had a heart attack. And all the testing that's been done, somebody mentioned about the feet and not feeling them. I definitely have peripheral neuropathy because the digital, like the ends of my vessels, are very ischemic. How much is the vascular system part of Parkinson's? Because I saw something about the mind gut, because I have ulcerative colitis, that it can affect the vagus nerve so that you do get these symptoms of flushing. I listened to you, Dr. Bruno, on your 2022 Hope Conference presentation, and your slide explained my side effects of my ulcerative colitis. I thought it was a session on ulcerative colitis, but it's
Bill,
very autonomic.
something's overheating. Okay.
And now that I have got my cardiac medicine, because we were thinking of surgery, but I've just got too many underlying factors. And I must say, I was even diagnosed as adult attention deficit because my brain would not go to sleep at night. And so you become just thoroughly exhausted. Going on the Parkinson's medicine, I sleep so well now. It calms my brain, but I do tire easily, and I think it's because of the heart. But do the women tend to have more autonomic symptoms? I think of my husband. He was a football player, and he also worked on a farm and did spraying. And he often worked on his carpentry without a mask. So I do think that some of the underlying things for him. But unfortunately, he passed away because of, they found underlying cancer. And boy, when he got that, it went so fast. They really struggled to find the primary lesion because it instantly went to his liver and lymph nodes because of the Parkinson's medicine. It tends to.
I'm sorry about that. It's pretty sad, Lorraine, and he went through a lot. I think,
Right.
Yeah, it's a lot. And I think a few topics that you mentioned that they are important. The first is you asked autonomic symptoms are more common. I said we don't know that with numbers, but I would say it's classically a bit more obvious in women, particularly the vascular symptoms like the orthostatic.
Right. I do think that because they kept me in the hospital for a whole month because number one, the heart-lung machine needed a part, and they thought they'd do more testing, and I hadn't seen a neurologist. And when they were testing, and I even got tests for the hematologist for lymphoma, and everything's vascular. And I was just wondering, because of having the ulcerative colitis, and I heard some new research or something that they think they might be able to predict Parkinson's with blood work.
Yeah, that's extremely interesting. And again, even in the two groups that we had, that came out a lot. Like GI symptoms for a long history with a diagnosis of ulcerative colitis or a diagnosis of a colitis of unclear reason, or the opposite, severe constipation, intestinal bowels, like irritable bowel syndrome, like that is very associated. We don't know how, but for sure, the GI system and the brain are highly connected in Parkinson's in both directions. So, and once like Parkinson's makes the GI system malfunction, but also the malfunctioning of the GI system seems to be a predisposing factor to develop Parkinson's. And that's why, we need so much information about diet and how medications affect the bowels and a lot of other aspects.
Well, I think the month I was in with observation and with the doctor deciding if I was a candidate for the triple bypass, they did so much testing and everything kind of like they tested whether or not I did have an adverse effect to statins. And he says, I can't do vascular surgery without you being on statins. And he says, while you're here, why don't we start you? And it actually helped.
Yep.
When I, read it was a side effect of statin drugs, so they took me off it. But I mean, there's so much chemicals involved.
Yeah, and as you mentioned with your husband, the important part of it is like it can show in so many different ways and behave in so many different ways.
Absolutely.
That it's important to ask because you may assume something is not related and it may be and may have a simple partial solution at least. So it's important to always ask.
He was on a study with the
Thank you, Dr. Bruno. Just
and
conscious
when
of time here for a second. Sorry, just conscious of time here. Is there any other questions in that? Because we're just getting close to 2:40. Deborah.
Comment. I'm fairly new to Parkinson's, but I noticed that when I open my fridge and go to get something out, my hand turns cold. I'm not hot. I never sweat. My hand turns ice cold. I was in Costco a few months ago and I went in the cooler where they have the vegetables and the strawberries and salads and stuff. I went in there, I was pushing the cart and I almost froze. I could not move. I got so cold, I thought I was going to stop breathing. And I backed out of there as quick as I could, which wasn't that fast. But I have real trouble with being cold hands and feet. And just if I'm around cold, I just freeze up. Is that normal?
I guess it depends. And again, it could or not be related. It depends on the context, on which time, if you take medication, what time of the medication that is. So if, you said you're pretty like young, pretty early in the diagnosis, if the diagnosis is the confirmed diagnosis, or maybe something similar, but yeah, it could be. The answer is it could be related. I have information like completely unsure about. I'm sure about it. No, we need to see the pattern. Also trying to find some way to deal with the cold because we live in Calgary and in Alberta, so it's something that you don't want to happen to you often. No, it's something we need to.
Yeah, I am a senior, but I've just had Parkinson's for a year and a half.
Yeah, it's very early, so it's something that you may want to discuss with the neurologist and said, is this something that I should pay attention or maybe keep a diary on so you know when it happens, if you take medications, what's the relationship with the medication and things like that.
Okay, thank you.
Very, very complex disease.
Yeah.
We need you. That's why we need you coming to the study and chat, and then we have plenty of time, and all these queries will come, and maybe some other person says, oh, I have the same thing, or yeah, no, that never happened. So again, it takes 4 hours. For us, it's very important, and it's not just for us, for you, it's for all the women that will be diagnosed with Parkinson's. And I think it's it helps like feeling less lonely, knowing that you're not the only one that is struggling with these symptoms and have these questions and want some answers. So feel free to contact Olga. Their email is there. There's also a link to the Parkinson's Association of Alberta where the study is published. And, if there is a women-related aspect that you want to discuss and you don't feel your care team has that information, you can always ask and says, oh, I heard Dr. Bruno has a specific interest. Could I see her once for a second opinion regarding this aspect? Not that I'm going to steal you from your neurologist, but I don't have the capacity. But at least, making sure that your questions don't remain unanswered. That is very important.
I just wanted to say I find it very interesting you were talking about colitis because our father has colitis. He has, first of all, it was ulcerative colitis, and now he has Crohn's, very deep ulcer or very deep wounds. And he's on Tivio, and it's not working, that medication. So they're going to try something a little stronger. What I find interesting though is that there's the correlation between the gut health and the Parkinson's. And I'm hearing that more and more. And also that I found out in researching that celiac is also something that's related to colitis and Crohn's and everything. So I'm wondering if this is why, if Parkinson's is on the rise because of these gut issues or not. The other thing I was going to say is my sister was talking about her foot. Our father has, you were showing the intern foot, Dr. Bruno.
Immersion.
Yeah, and it kind of, the way it kind of turns out, I think it is, and it's kind of stuck there. So he gets it and he can't move it. So I found that interesting that you're bringing those up, because we asked the neurologist about that, and they said it's probably from his back pain. Because he also has osteoporosis, and he's getting a lot of back fractures, compression fractures. So I'm not sure which is causing it, if it's what you were talking about, or if it's to do with the back. It's hard to say, but his foot is constantly going like that now. And he goes through phases. So
Yeah, I would say that if it's a fluctuating symptom that comes and goes, and it always happens in the same pattern, it's much more likely to be a movement disorder like foot dystonia than a nerve problem, because nerve problems associated with back issues just would produce weakness and will be there all the time, or the pain. But is there not really a reason why the back problem would make a foot move in a particular way and stay like that, stuck, and then come back to normal? Does it make sense? So it's not that I want to be overconfident because I have not seen it, but but I think it's a good reason to re-ask, could this instead be foot dystonia related with the Parkinson's, and is there anything else we could do?
okay. Interesting. Okay, and the other thing I was going to say, that lady who was talking about the cold, I'm just wondering, I don't know, not a doctor, so I'm not going to diagnose her, but I have arthritis, and I notice when I'm in severe cold, like when I go in the refrigerators and stuff like that, it hurts my joints and movement as well, and it can affect. So I'm just wondering with Parkinson's, if that would be something that would be related.
And I think what you mentioned is very important, Melinda, because again, these are the combinations that we have never explored. But arthritis is extremely common. You know, one of my friends just turned 40 and got an MRI and says, like, incipient signs of osteoarthritis. Yes, we all will have it, especially as women. Like, bone health is very important. And what happens with the combination? If you have a bit of stiffness because of Parkinson's plus arthritis, does that predispose me to have more issues with my joints when exposed to something? Those are the types of questions that we're trying to learn more from and bring some answers.
Right, exactly. Thank you so much for doing this.
Oh, no problem. And again, feel free to contact us. And if it's anything that you may need, you know how to find us. We're always around. And thank you, Ree, for organizing it. And again, if we're a small group here, but if you are in groups and you feel that there are other women that may benefit from the webinar or the study, please let them know, and we would want to hear from you for sure.
Could someone from Edmonton join, or is that out of? Yeah.
We have a few Zoom sessions planned in the future. So because Brandy asked us those questions, we were planning to do it virtually, and we said yes, we want to be very, very open. So yes.
Okay, because my mother-in-law has Parkinson's as well. So
for sure.
Might be interested in joining. It might be helpful for your focus group. And
exactly. Every participation is helpful. Thank you.
Thank you so much for doing this. We really appreciate it. Appreciate your time, your expertise, your feedback and support.
No problem. We're here to help. That's our work. Okay, and see you. Thank you for coming. Bye-bye.
Yeah, thank you.
Thank you, everybody, for joining. Thank you, Dr. Bruno, for your time. Linda, sorry, it looked like you had a comment quickly.
No, I got a message that said somebody wants you to turn off your mute. And I assume it's the one who wanted to know who was from Edmonton. Okay.
And also, we will not. So the recording will stop by the end of my talk. So don't worry about any personal information
Sure,
shared
I don't
because
care.
it's not gonna be included.
Sure.
Yeah.
Okay.
Awesome. Thank you,
Bye
Dr.
bye.
Bruno, for your time. Thank you, everyone, for
Thank you.
joining.
See you.
Take care. I hope
Thank
you
you,
all have
Bree,
a
for
lovely
setting this up.
day.
Yes.
Thank you, Bree.
Oh,
Thank you.
okay. How do I get out of here?